Everyone, thanks so much for joining us today. We are going to be talking about medical oversight in addiction treatment, and we have our clinical director, Rich Mcdonald, here, and our registered nurse, Susie Ware, to give the presentation. Just a couple things before we start. If you want to ask questions at any time, you can use your GoToMeeting control panel and type a question in there, and we'll see it and make sure it gets answered. And there's a few handouts in the handout section of the control panel, which you can download. There's a few of our newer collateral pieces, and then our program overview and an admissions guide. That's all I have for you guys, so I will let Rich and Susie kick it off.
Awesome. Thanks, Kayla. Hi, so as Kayla said, my name is Rich McDonald. I'm the clinical director. I have been working in treatment for about 6 years now, 6.5 years, I guess, and well, residential for 6.5 years. And then before that, spent a couple years working in an outpatient setting that also offered some psychiatric support to clients, and I'm excited to talk about this. It's an important piece of what we do at Wasatch Crest, and it can make a real impact on our clients. So happy everybody joined us this morning, and I'll let Susie introduce herself.
Hey, I am Susie. I'm a registered nurse. I have been a nurse for about 15 years. I've only done substance abuse. I think it's been about 4 years now. It's crazy. Rich took a chance on me. I'd never worked with substance abuse before, and was lucky enough to come here, and I have thoroughly enjoyed it. I find it fascinating and very interesting, along not just the substance abuse, but with the mental health that comes along with the substance abuse and all the things that go along with it. So I am excited to be here.
Awesome. Thanks, Susie. So we thought we'd just kind of talk about, what we do and how the medical piece fits in across the various levels of care. And, really, it all starts on the front end with our admissions team, doing the best they can to get accurate information from potential clients, and really looking at, can we safely treat them at Wasatch Crest? Do they require detox at a hospital? And really trying to understand where they're at. And I think, to treat clients safely, there's always that assessment when they actually arrive as well. And there's times where we felt good about bringing somebody in, and they arrive and their condition's worse than they had reported. So we'll transition back over to a detox if that's necessary. In Utah, we have a state license from the Health and Human Services, our state licensing. We actually do have a license for social detox, which is not quite as cut and dry as I wish it was. Essentially, it allows us to deal with some detox symptoms and withdrawal symptoms, but non-acute, and oftentimes it's usually, meth or heroin is the drug of choice. Benzos and alcohol makes it a little more dangerous. So Susie does a really good job of kind of assessing those clients as well. And do you want to just talk a little bit about what goes into that?
Yeah, so I think one of the biggest challenges is having a client come in and not knowing totally the full story, because a lot of times, not all the time, but a lot of times with some of these clients, they say certain things to get what they want. And medication is a huge thing. I think once they decide to come into a facility that they feel and think that medications are like the only thing that is going to get them through this, which a lot of time is true, but a lot of times it's not. So I think with coming off of alcohol or benzos, that's the one that we're really, really careful with. And what we do is we assess prior to them coming in, hopefully, is what we can do as best we can, to how much they've been drinking or how much they've been taking, in regards to if they need to go to a detox center prior. If they're able to come here and we feel comfortable with them coming here, we do what's called Librium to get them through. And we only do a taper. We only do about a week's taper with Librium, because the longer they're on Librium, the more, first of all, the more dependent they come on it, because it kind of relaxes them and kind of makes them feel a little bit, relaxed and not so stressed, which is what we want for alcohol or benzos detox, because of course with alcohol and benzo, the thing that we are trying to prevent is seizures and that stress of the body. So that's, we only do the taper for about 7 days because we don't want them to get dependent on that, but we also, we call it what's called the green monster. Once if they're on Librium for quite a while, they can become very irritable and mean. They actually get really mean. So we try not to keep them on that for very long. So if they're lucky that they can come here prior to not having to go to detox center, that's what we'll do for them. And then with heroin and meth, obviously there's nothing really for meth except for them to sleep it off. We kind of just give them a couple days to sleep it off, make sure they hydrate very, very well when they are not sleeping. And then for heroin, what we do is a buprenorphine taper. If they need it, we try not to. It's kind of our one where we hope for the best that they don't want it, but I would say 95% of our clients want a taper, which is okay. But we try to do just a taper because, of course, what we're here for is for them to not be dependent on anything. And we try to talk them into not, feeling like they need a maintenance dose or not. And I'm not saying that maintenance doses don't work, because I feel like some clients definitely work best on that, and it does do well for them. But for the first part, when they come, we talk to them just about a taper, and that one once again is a 7-day taper, and we kind of taper them down to just kind of help with those symptoms, those withdrawal symptoms.
And it's been a nice kind of evolution, I think. Initially, my views on maintenance has changed over the past few years in particular, and I know it's still kind of a subject that people get really excited about, and there's energy on both sides, for and against. But the thing that I'm really proud about here is that we really do work with the medical team and the therapists and try to understand the client's situation and their history and make that decision on a case-by-case basis. I think it's kind of like, the therapeutic approach. There's not one specific approach that we as therapists use with the client, and same with the medical piece, right? So there are some people that the maintenance will save their life, and like understanding who they are and where they're at. And then also, obviously, they do have input. It's their recovery, it's their it's process, but we want to make sure that we're doing it for the right individuals and supporting the ones that maybe it's not right for to, move forward without that maintenance. So it's been nice. Our medical director and psychiatrist and Susie, our nurse, they do a really good job of collaborating and really trying to understand that history and help clients get stable. As far as like support staff and clinical team, when somebody is coming in and we identify that they're going to have withdrawal symptoms and we know that they're being medicated, we'll do the first 24 hours. We get eyes on every 30 minutes, vitals at regular intervals. And then after that first 24 hours, Susie and the doctor will let us know, okay, we got to continue eyes on every 30 minutes, or can we go to 60 minutes? But we have an electronic surround system in our EMR that's been really nice. It kind of gives us all some comfort, because I think the piece, the medical piece and the medication, and that's probably one of the riskiest things we do. Not probably, I think it is one of the riskier things that our clients that we need to monitor closely. And I feel like we've done a really good job and kind of taken from all different approaches. It's been really nice.
And with that, with medications, because they're not on their drug of choice anymore, the biggest thing is definitely assessment and questions for these clients, because some of these clients, they'll bring in every medication they've ever been prescribed before, and they'll bring it in. And so assessing them and knowing what is best for them, we try not to, what we don't want is we don't want them to come in and then we just throw them on a whole bunch of medications because they say they need it or they feel better on it. What we try to do is assess them very thoroughly, hopefully after their withdrawal symptoms and their detox, because we want to provide them the best medical care with the medications that we feel will be best for them. So we kind of take it by a day-to-day basis. Our physician's really good about doing, less is more, because a lot of times, of course, most of the clients want the, the highest dose and the most frequent and all that. So we try to kind of explain to them and talk to them that we kind of want to see what their bodies do, without, such and such med, or if we want to try this medication, and of course we listen to our clients, and if they say, this is the medication that works for me, and we will do what is best for them. And I think it's been really nice to be able to correlate with both the physician and the psychiatrist to kind of just get what the best possible care for them medically, not just physically, but medically and medication wise for them as well. So
awesome. Well, and that is a really important phase of the treatment process, right? Is that stabilization when they're coming in, making sure that we can get them engaged. The other piece is that if we bring somebody in that really needs hospitalization or might do better in a medical detox, we're using time that we might be able to use, a week later to actually get them fully engaged in treatment. I've seen, having somebody arrive at Wasatch Crest, hit the ground running. If we're only getting 30 days of residential treatment, spending a week of it in bed can be really, it's a waste of resources, really. And so it's been kind of a process, and I've loved learning from our medical team. Once they are in treatment, then they have the opportunity to meet with Dr. Brindley, our psychiatrist, and really look at the mental health component. And then we continue that through day treatment. And by the time they hit outpatient treatment, they should have begun working with a primary care physician or a psychiatrist outside of Wasatch Crest, so that transition can go smoothly and help them long term. I think I was trying to think about, there's an old school view, and I'm a person in recovery, and I've run into it in the 12-step community. There's certain AA groups across the country that are really hardcore about no mind-altering substances, which they throw antidepressants into the mix there, mood stabilizers, like you should be on nothing. And I've seen it make such an incredible impact on people's lives that I think that approach, hopefully is fading away. I think it largely has. I think most of us have hopefully accepted that there's a time and a place for these medications, and it can really change somebody's life, and it's really important. I was trying to think of an example, and Susie and I were talking about this before, of somebody that I've seen it really impacts their lives. So we had a client that came in early spring last year. We made a diagnosis, and we could tell that he was really struggling to stabilize his mood. He was up and down, volatile, really emotional, from crying one minute to anger the next day. Like he was really struggling, and he was also unwilling to even discuss medications. I was working with him as part of my caseload. I encouraged him the whole time he was with us to meet with the psychiatrist and the medical team and really get an assessment on medication and see if it could make a difference for him. And by the end, he was so resistant, I had to take the harm reduction approach and work through that and respect his wishes, but make sure that he understood that I think he would really benefit from an assessment. So he left. He stayed sober for I think probably 2 or 3 weeks, and then I got a phone call from somebody in the court system saying that he had relapsed and caught some more legal charges. Well, it was a big enough deal this time around that they required him to begin medication in the court system, and we worked really hard to get him released and back into treatment. And he had a diagnosis of bipolar. He came in on medication, and to watch and see how that affected him and the incredible change it made in his life. He has been, I believe, sober for 120 days was what he just told me. He's still involved in our alumni programming. He's doing so well. He started school. He's got a full load. He wants to become a social worker. And he's the first person to talk about that medication and the difference it made in his life. You know, he said he stays forward thinking and positive, but he'll say regularly, I can't believe I was so resistant. This has changed my life. I'm a different person. And so it's really, really important that we help our clients see, and we're the professionals. You know, Susie and the doctors and psychiatrists, they're the professionals, and we've got to respect their wishes and be client-centered, but we also have to be able to push back a little bit and make sure that we're sharing our expertise and being able to help them.
Yeah, I think that's one of the biggest things is that, yes, we hear these amazing success stories and we see them and they make us so happy, you know, but with medications, it is kind of a fine line because, like I said, we do have clients that come in and just want to be put on all these meds because they think all these meds are going to make them feel better. So it's been really nice to be able to work with, you know, psychiatrists and physicians, you know, to help these clients realize that, yes, medications help, but it's not just to get rid of feelings and not have to think of things and not have to deal with things. So it's been really nice to be able to, you know, combine together to realize, you know, medications, but yes, let's work through these things that these clients are obviously trying to avoid with medications so that we can get them to see and realize what we can do to work through those things. And then also with the combination of medications to get the best care. And of course, some of these clients, you know, they don't want to go through, you know, they don't want to have to deal with the things they've, you know, dealt with in life or done in life. But, you know, in reality, that's what we need. Our hope is for every client to be able to work through things so that they can, you know, have the best life possible. So, yeah.
Flip the next slide, Kayla. Thank you. I think, you know, the next piece of it is understanding that our residential treatment really is stabilization. Oftentimes we'll get people that come in and it's like, you know, week one, they're still acclimating to the milieu and becoming familiar with the treatment and the program and beginning to do the work. And they have, you know, had no medical care for years sometimes, right? Medical, dental, and really helping them identify that in residential is important. We do our best to help them start getting to some of those appointments, but at the same time, you know, while they're with us in residential, we're really identifying those issues, getting, you know, testing and anything we need to help them understand where they are at medically. And then it's in the day treatment and IOP, hopefully before they leave, they've got everything lined out. We do everything we can to make sure that, and when they step back, you know, step down into day treatment, sober living, we really, they understand where they're at and where they're going. Oftentimes, our clients are, there's little things that I always call them back doors with clients, right? Like excuses, like, you know, maybe they have had a knee injury or a back injury, and it's like, let's figure out the process and how they're going to handle those major injuries in a safe way that's going to support their recovery long term. You know, my own experience was, you know, my first shot at recovery was having morphine at a hospital, which was absolutely necessary, but the way I handled it, I relapsed within the next, you know, 14 days, and it could have been handled safely, but educating clients, working with their doctors. My family practice doctor knows that I'm in recovery. He knows, you know, I laid that out for him while I was in treatment. And so does my dentist. So I'm really careful that way in helping clients understand that and coordinating and collaborating with the medical team and knowing where the clients are at. You know, at our weekly clinical meetings and check-ins with the medical staff and the clients, also like monitoring side effects and really being part of a treatment team, I think is the biggest piece. We had an experience yesterday where one of the clients kept falling asleep in group. And so the first thing that the clinician did was speak with the medical team and say, hey, are they on something that we can, they're falling asleep in group, and making adjustments that way with the medical team and the clinical team, and sharing observations. It's really easy to see something and not reach out to the medical team and let something go that could be addressed while they're with us. I mean, ideally, if they're here 30 to 45 days in our residential program, we've made some adjustments to their medication. The trick with some of that stuff is that it takes, 30 plus days to really see the impact of some of the antidepressants and mood stabilizers. And so making sure that they have the care that they need, that's been communicated to their doctor once they're no longer in our care, and, supporting long-term recovery.
I think that's the biggest thing is getting them stabilized here. And it's hard because yes, a lot of these medications take, weeks to get the full effect of. So our best thing that we can do is, sometimes we only get these guys for 30 days. Of course, we would love to have them 60, 90, as long as we can have them, because, in my belief, I think the longer they're here, the better outcome we could get for them. But if we only have them for 30 days, we make sure that they, when they leave, we automatically give them a 30-day supply of medications to give them time to get settled, to find a preferred care provider. We try to get them appointments with a preferred care provider before they leave, so they have that set up. We try, if they need dental, we try to figure that out with wherever they live, and with their insurance. And even with like Vivitrol shot, we try to make sure they get a Vivitrol shot before they go, and that they have a refill and a doctor that they can go to immediately for their next shot, that they don't have to wait for it. Or, if they're taking naltrexone, we just make sure that we try to make sure that they are sort of semi-stabilized prior to leaving, so that they feel a little bit more comfortable with knowing that they have all this stuff set up and available to them, than just going out to the world and not knowing what to do. Because I think that's the hard part. Once they leave, where do we go? What do we do? Who do we see? And so I think that's a big deal. So I think that's been really helpful for the clients, knowing that they have that thing to lean back on. So,
and then sharing, I think, medical records on the front end and the back end,
yes.
Making sure that we have as much information as possible. The other thing that we've been focused on recently is making sure that we're asking these questions as part of the family communication and family work. A lot of times, if there's loved ones involved in a client's treatment, we get really good information from them, and then making sure that it's being passed along. Whether somebody is reporting something that maybe they don't have in their history, but minimizing things often is what's going on as well. So it's getting that full picture and really collaborating. Recently, we've been working with one of our clients' family practice doctors that they're returning to, and he reached out and had a release of information, and I told him a little bit about where the client was at, and I was impressed that the fact that when they leave here, they have the picture of the same information that we have, and they can help support them long term. Do the next slide, Caleb. Okay, lasting recovery. What is the purpose of treatment? I think was what we were getting at with this slide, right? What we're trying to do for our clients is give them a quality of life
that they didn't think they could have.
Yeah.
Most of the time, they don't feel like they can have this type of life with the things that they have done or gone through. I think that's a huge thing.
And we've stigmatized mental health in many cases for many years. And a lot of times, those medications are a crucial it's something that they can't have the most thriving, well-rounded, amazing life possible without the support of medication, dealing with some of the mental health components, and really understanding how they can, find relief without medications is important as well. One of the, we do a lot of mindfulness meditation and yoga while they're in residential treatment, and then put together a treatment plan, an aftercare plan that includes that. Like, are we building in time in their schedules to do the relaxation? Are we working with emotional regulation skills, especially anxiety, breathing, and really teaching the clients that reaching for a pill for relief is also not the answer. So it's that balance. Like, it's really difficult. I use this analogy about anxiety with most of my clients that report any type of anxiety or panic. It's like, you're a little kid at the community swimming pool and there's the highest high dive, and you think your friends are all telling you to do it and somebody else has done it, and you're going, okay, I'm going to do this. So you walk all the way to the top of the diving board, you're at the end, and you're going, oh my gosh, this is really high, I don't think I can do it. So you jump off, and once you've gone off it once, the second time's easier, the third time's even easier. And I think a lot of the stressors in daily life are like that. We learn that we can make it through something. Like, acceptance and commitment therapy is one of my favorite modalities because of that. Like, understanding, wow, I might feel anxious in this scenario, and I have the tools to walk through it. I know I'm going to make it to the other side. So it really is, that collaboration that helps keep our clients, like, they guarding their recovery, I guess, and not needing to always reach for medication when something comes up, and teaching them that they can walk through it. It's hard also when, you're in treatment, you've got somebody eyes on all the time. You've got somebody making your food, you've got somebody driving you to rec activities, you've got all of this, and you get out into the real world and the additional stressors, it's back to real life. And so really understanding those components of a client's, real life situation and being able to address that while they're with us.
Yeah, and I think, it's baby steps. These people are literally starting from the beginning. So stressors can be from anywhere, from, trying to get your kids to school or making dinner. Like, those are big, I know those are big stressors for me some days. So, when, little stressors that can kind of just tip them over the edge, like, they're starting from the very beginning. So we kind of try to teach them and help them realize that if we can get through this, if we can get, getting all the kids ready for school and getting them off to school on time, or making dinner for everybody when they get home, like, baby steps to these bigger stressors in life that will help them be able to realize that they can get through them without a pill or a syringe or a bottle or whatever, that we can get through it. Yes, it's hard. Yes, it's not what they're used to, but if we can, while they're here, we can show them that we can get through them without stuff, that it makes it a little bit easier for them to kind of get out to the real world and hopefully have a better future.
Awesome. Thanks, Susie. Yeah, does anybody have any questions?
Just as a reminder, everyone, you can ask questions using that GoToWebinar control panel, and if you type them in, we'll make sure to get them answered by Rich and Susie. So feel free to do that now if you'd like. And then in the meantime, these are upcoming webinars. Next Friday, we're going to be talking about understanding opioid addiction and the rising addiction rates that are related to the pandemic. And then the next Friday, on February 12th, we're going to be talking about recreational therapy modalities with our Director of Recreational Therapy, Adeline Cook. And then I think that's all we have for you guys. So that's our admissions line. It's 24/7, and our website, wasatchcresttreatment.com. As a reminder, there are some handouts in the handout section of your GoToWebinar control panel, just like pieces that go over our adventure therapy program, our alumni program, our program as a whole, and our admissions process. And you can download those straight from the control panel and take them with you. And it doesn't look like anyone has any questions. So thank you, Susie and Rich, so much.
Yeah, thank you. Have a good weekend, everyone. She is.